attendees are in listen-only mode.
Hi everybody, welcome to the National Hispanic and Latino ATTC's webinar, Meet Your New Clients, Hispanics and Latinos. Today's webinar will be presented by Dr. Luis Torres. He's an assistant professor in the Graduate School of Social Work at the University of Houston, and he's also a researcher with both the Center for Drug and Policy Research and the Child and Family Center for Innovative Research. I will tell you a little bit more about him later. During today's webinar, all participants will be muted. The audio will be streamed through the computer, so please make sure that your computer speakers are turned on and up to hear today's presentation. Okay, first I'm going to review a few housekeeping items with everyone. If you notice that your viewer does not fit your screen, you can expand it by clicking the expand button. It is located in the top right corner, indicated by the red arrow. Okay. Now you see that your viewer is expanded to fit the entire screen. Also, you can collapse the GoToWebinar toolbar in the right of your screen by clicking the small red arrow to the left of the toolbar. There you go. And then click the arrow again to expand the toolbar again, and it will expand. For today's webinars, all participants will be muted. As we move through the presentation, if you have a question for our presenter, we ask that you use the chat box on the toolbar, which is right here. Simply type your question and hit send. We can pause for, we're gonna pause midway through the presentation when Dr. Torres is gonna give us a case vignette, and he's gonna ask some questions, and you can write the answers on the area, on the chat box. But if you have any questions during the presentation, you can write them there, and we'll try to answer them at the end. A recording of today's webinar, along with the PowerPoint presentation slides, will be available at www.attcnetwork.org/itrainings. Also, we are providing one NADAC, NVCC, and ICRC continuing education credit that is available to those who attend today's live event. So if you're interested in obtaining these CEUs from these organizations, you may email us at hispanic@attcnetwork.org. We're going to give a little history about the ATTC network for those of you who are not familiar with it. Today's webinar is sponsored by the National Hispanic and Latinos ATTC. As of October 1st of 2012, the network has been restructured, and now it consists of 10 regional ATTCs and 4 national focus areas ATTCs, along with the network coordinating office. As you can see by this map, the ATTC network regions were realigned to better fit the current HHS regions. And the 4 national focus areas ATTCs, you can go back, are listed on the left. Today's webinar is the second in a series that the National Hispanic and Latino ATTC is going to be offering. The ATTCs are sponsored by SAMHSA. SAMHSA strives to reduce the impact of substance abuse and mental illness on America's communities through its programs and services, and demonstrates that behavioral health is essential to health, that prevention works, treatment is effective, and that people recover from mental and substance use disorder. If you want to learn more about SAMHSA, you can visit their website at www.samhsa.gov. Okay. So now we're going to learn a little bit more about Dr. Torres. As I mentioned, he's an assistant professor in the Graduate School of Social Work at the University of Houston, and a researcher with both the Center for Drug and Social Policy Research and the Child and Family Center for Innovative Research. Prior to coming to the University of Houston, Dr. Torres completed a 2-year NIDA-funded postdoctoral research fellowship in the George Warren Brown School of Social Work at Washington University in St. Louis. His research agenda focuses on health disparities, specifically co-occurring mental health, substance use, and medical disorders in Hispanics. Also, on family strengthening efforts with a focus on Hispanic communities. He's currently the project director of an NIDA-funded study which examines the health consequences of long-term injection heroin use in aging Mexican-American men. Dr. Torres is also co-principal investigator in a national implementation evaluation of grantees in the Federal Hispanic Healthy Marriage Initiative, focusing on issues of cultural resonance and cultural adaptations, and co-principal investigator in a national study examining programs that serve Hispanic fathers. Dr. Torres is a native of Puerto Rico, has a doctorate in clinical psychology from Fordham University in New York, and over 20 years of clinical, administrative, and research experience. So now we're going to turn over the screen to Dr. Torres. Okay. But first, Cindy, are you gonna, she's gonna be asking some poll questions so we can get to know our attendees.
Thanks, Therese. Yeah, I've got about 5 quick questions for our viewers just so we can get to know you a little better. And the first question, do you currently serve Hispanic and Latino populations with substance use disorders? So we'll give you about 5 seconds to answer that. And okay, I'm going to go ahead and close the poll. Most of you have voted. And 56% say they do currently serve Hispanic and Latino populations. Okay, you ready for the next question? Should I just go through them?
Yes, we're
okay.
ready.
Next question, are you planning to serve Hispanic and Latino populations with substance use disorders in the next 6 months? Okay. Very similar responses. I'm going to close the poll and share the results. 63% say yes. Okay. And next, which field of work do you represent? I only had room for 5 choices, so you can vote on that. And if you want to use the chat feature, if your answer is other, go ahead and write in which field you do represent. We can record that. Okay, I'm going to give you about 3 more seconds. And I'm closing the poll. Okay, the results are 27% for substance use disorders, 46% of you are mental health. We have no one today on with primary care, 19% with education, and 8% represent policy and political affairs. I've got a couple of people writing in community mobilization, vocational rehabilitation, and people that represent both substance use and mental health. So thank you. Okay, I'm going to ask the next question. There's only 2 more. And what is your current professional role? Again, please feel free to use the chat box if you're not listed here. Counselor, therapist, social worker, case manager, nurse or physician, student or faculty. Okay, we have a clear majority here. I'm going to give it 3 more seconds. And I'm going to close. And the results are 52% of you are counselors / therapists, 29% social workers. There are no case managers or nurse or physicians, and there's 19% representing student or faculty. We have an educator, and we have a retired social worker also with us. Okay, last question. and what type of setting do you currently work in, either inpatient or, whoops, that's supposed to say outpatient, substance use disorder treatment, psychiatric facility, primary care unit, managed care, or a university. Okay, and again, write in anything that's not covered. I got 50% of you finishing up here. I'm going to give it a few more seconds. Okay, I'm going to go ahead and close the poll and share. Makes sense that we have the 35% in 35% in substance use disorder treatment, inpatient or outpatient. Actually, we have the most, 45% in the university setting, 15% in managed care, 5% in primary care, and we have quite a few. We have somebody wrote in supported employment, psychologist at a VA, I guess that's the Veterans Affairs hospital, volunteer community organizer. Okay, I think that gives us a good picture of who's on, so I'm going to ask Dr. Torres to go ahead and share his screen. Make sure that I have him. Okay, Dr. Torres, it says you are the presenter. I think you have a button to click.
I don't see it.
Okay, tell you what, I'm sorry. I'm going to take it back for a second, and we'll try that over again.
It had been that. There you go.
Oh, I took it. Now I'm going to give it back to you.
Right.
Okay. And you should have a button pop up. Sorry, everyone, for technical difficulties.
There you go.
There you go. Thanks.
Thank you. So it's on me now?
Yep, your screen is showing.
Thank you, Cindy. Good afternoon, everybody. Buenas tardes a todo el mundo. It's a pleasure to be here doing this first webinar of the National Hispanic and Latino Addiction Technology Transfer Center. I'm located in Houston, and the game plan for this webinar, I'm going to go through about 9 slides, giving a little bit of background about meeting your new clients. And the reason why we chose to title the webinar Meet Your New Clients is because, as we all know, by virtue of your participation in the webinar, the Hispanic population has really been increasing tremendously over the last 15 or 20 years and moving into areas that previously had very few or no Hispanics. So in a lot of settings and for a lot of service providers, Hispanics or Latinos are a new population. So that's why this inaugural webinar, which complements a fact sheet that was released about 2 weeks ago by the National Hispanic and Latino Addiction Technology Transfer Center, is to sort of give an introduction to folks who may be new or relatively new working with the Hispanic community, a sense of who the community is. So I'm going to talk about for about 9 slides to sort of set the stage, and then we're going to look at a vignette, a client vignette that's taken from a book chapter that I was a co-author on a couple of years ago on Latino Heterogeneity, just to give us a sense of the broad diversity that exists within the Hispanic community itself. And then I'll wrap up with about 6 or 7 slides about some of the challenges faced by the community in the context of the vignette. So that's basically the game plan, and I plan to leave time at the end for questions and answers. So first, to make sure that everybody's on the same page, a definition about who is Hispanic or Latino, and the Office of Management and Budget of the federal government, which approves research studies and service projects and that sort of thing. It's sort of the federal IRB, in a sense, defines Hispanic or Latino as a person of Mexican, Puerto Rican, Cuban, South or Central American, or other Spanish culture or origin, regardless of race. So Hispanics can be of any race. The term Spanish origin can be used in addition to Hispanic or Latino. The census definition is a little shorter and says a person of Mexican, Puerto Rican, Cuban, South or Central American, or other Spanish culture or origin, regardless of race. So again, this idea that Hispanics can be of any race. The key distinction between the two of them is that the OMB definition is actually assigned by others, and the census definition is actually self-assigned. You know, nobody comes to your door and check to see if you're a Hispanic when they're taking the census. You know, they ask you on the form, and if you identify as Hispanic, you say yes, and if you don't identify as Hispanic, you say no. How about a little bit of sense of the growth of the Hispanic community? As of June 2012, 17% of the U.S. population, or 52 million individuals, identified as Hispanic. And that's almost a 50%, 47.5%, 48% increase between 2000 and 2011. Moreover, this tremendous growth will continue unabated, and the projection is that by the year 2050, almost a full third of the U.S. population, or 133 million individuals, will identify as Hispanic. And considering that to date Hispanics have thwarted all growth projections, that's probably going to happen much sooner. About 63% of all Hispanics in the United States are of Mexican or Mexican-American descent. So they're by large the largest group of almost 2/3. Other groups are, in order of descending quantity, Puerto Ricans are the second largest group, followed by Salvadorans. Cubans and Dominicans are pretty much tied. Guatemalans, Colombians, Hondurans, Ecuadorians, and Peruvians. So those are the 10 largest groups, and you have a link in the slides, which will be made available following the webinar, to demographic profiles that are prepared by the Pew Hispanic Center for the 10 largest groups. Of course, there are Hispanics come from 26 or 27 different countries throughout the Americas and the Caribbean, depending on how you count. So these are simply the 10 largest groups. Not to say that the smaller groups are less important. One other fact that's in this slide number 3, is the median age. So Hispanics are a very, very young group, which is really important for the service delivery in terms of how important they are to the national economy. And we'll return to this point a little bit later. In terms of income, poverty, and health insurance, again, these are national figures, and these are average statistics, so not all Hispanics are going to fall in these groups. You know, as a group, Hispanics are not only younger than the overall non-Hispanic population, in fact, almost 10 years younger than the non-Hispanic population in the country, but they're also, as a group, more impacted by poverty. The median household income for Hispanic households in 2011 was $39,000 compared to $54.4 thousand for non-Hispanic whites. The poverty rate for Hispanics in 2011 was almost 26%, compared to 11% for the non-Hispanic white population, and the percentage of the population, the Hispanic population, without health insurance in 2011 was 30%, compared to 11% for the non-Hispanic white community. When you break these poverty statistics up by nativity, looking at native-born Hispanics, so these are U.S.-born Hispanics versus foreign-born Hispanics, Hispanics that have immigrated to the United States, the statistics become a little bit more bleak. So the median income for foreign-born Hispanics is lower than that for native-born Hispanics, about $36,000 versus $42.5, and the poverty rate is about equal, 25.8 for foreign-born and 25.9 for native-born. That's a statistical dead heat. and the rates of insurance are also dramatically larger. Over half of all foreign-born Hispanics in the United States have no form of health insurance, compared to 18% of those that are born, Hispanics that are born in the United States. And these all have critical importance to service delivery and to quality of life issues, and to the kinds of psychosocial stressors that are often associated with poverty. And we'll return to this point later in the presentation. In terms of families and children, there are about 10.5 million Hispanic households in the United States in 2011, and almost 2/3 of these households are composed of two-parent homes, so two-parent families. While this may seem like a very large number, almost 2/3 of it, you go back maybe 15 or 20 years, and that number was much, much higher. So, as is the case with other groups in our society, the value that's ascribed to marriage has been declining, and with that, the number of single-parent-led families has also been increasing. That's the case across the board, and it's certainly the case for Hispanics. Again, pointing to what a young community the Hispanic community is. 39% of Hispanic households consist of a married couple younger than 18 years of age. That's quite remarkable when you think developmentally, psychologically, financially. Where a person who's 18 years old, not even out of adolescence yet, may find themselves, and many of these individuals are already raising families of their own. Again, these are facts that have important implications to service delivery. Language is another important factor. 75% speak a language other than English at home. That's a statistics that's often misused and misunderstood. That doesn't mean that English is not spoken in that home, but it means that the language that's spoken in the home, the preferred language, is one other than English. Typically what you have in immigrant families is that as the kids begin to grow and go out into the school and begin to acculturate more rapidly, once they enter their school-age years, they're English speakers. And the immigrant parents at home, first-generation immigrants, may be less fluent in English or not fluent at all. And again, that has implications for service delivery, but also with how parents navigate the broader systems in society to the benefit of their children, schools and medical settings and those kinds of settings. In terms of education, again, as a group, Hispanics are less educated than non-Hispanics, although we're making great strides in the right direction. In 2011, 27% of Hispanics 25 and older had at least a high school education, compared to 29% of non-Hispanic whites. So there we're about even. But when we look at the need for a college degree, and there's been a lot of stuff in the press lately about how increasingly important a college degree is becoming. During the Great Recession, in the last couple of years, individuals with only a high school education fared far worse than individuals with a college degree, even though everybody across the board was impacted. And just a couple of weeks ago, there was a big article in the New York Times about law firms in New York City that were requiring, bachelor's degree to be filing clerks. So the tougher the economy gets, the harder it is for folks with lower levels of education to actually find jobs, good-paying jobs. And there we see a much wider gap. 13% of Hispanics 25 and older had a bachelor's degree or higher in 2011, compared to 32% for non-Hispanic whites. So again, the dropout rate, I don't have it in the slide, but Hispanics have very high high school dropout rates. College retention rates are lower, but we are making strides. There's some good news coming out in the past year about increasing retention rates for Hispanics and other groups as well in college. A testament to the significant growth of the Hispanic community are these last two bullets, that already today 1 in 5 children in elementary and high school are Hispanic, and one of every 4 children enrolled in Head Start and Early Head Start are Hispanic. Again, leading to the continued growth of the Hispanic population in the United States. Where are these Hispanics located? That's your next slide, and we look at this pie chart that you have here, and you see the largest number are in California, 27.8, followed by Texas. And when you take California, Texas, Florida, and New York combined, almost 2/3, 63% of all Hispanics are located in those 4 states: California, Texas, Florida, and New York. The other states that you see there, Illinois, Arizona, New Jersey, Colorado, these are also considered, traditional receiving states for Hispanic immigrants, or states where there were already a lot of Hispanics to begin with. When the U.S. Acquired territories during the U.S.-Mexico War, and then 1/4 of the Hispanics are in all other states. And we're going to look at in a moment at what are some other states where Hispanics are moving. And this slide is the slide that really, I would call it the money slide. It talks about why this webinar is important, why many of you might be interested in learning more about the Latino community or the Hispanic community, and it's this phenomena of new destination states. These are states that historically had very few or no Latinos, and in the last decade, the last 15 years, we have seen an explosion. You see the Middle Atlantic region, North Carolina, Georgia, South Carolina, for example, and the adjacent states, Kentucky, Tennessee, Alabama, Arkansas, that whole area, there's been a tremendous explosion in the Hispanic community. And many of these states, many of the cities and towns within these states are really ill-equipped to absorb the rapid growth of a population. Many are immigrants, many are moving from north to south, so they've been here for a while, they're very acculturated, but many others are immigrants, and they go looking for work, and their English proficiency is more limited, and there's great need to attend to these communities, and many communities are struggling. You look at Nebraska in the middle of the country, it's a big agricultural state. Of course, you look at Nevada, close to California, so you see a little bit of a spillover effect there. And even Utah. And Utah is an interesting experience as well, because many of the Hispanics that are relocating to Utah are actually Latter-day Saints, members of the Church of Jesus Christ of Latter-day Saints, or commonly known as the Mormon Church, and whereas the Hispanic community as a whole is more Catholic and Christian. So there are even faith differences, in terms of when you talk about heterogeneity. That really, if you know a little bit about Latin America, that shouldn't be a surprise, because the Church of Jesus Christ of Latter-day Saints actually does a lot of missionary work in Latin America. So many Hispanic immigrants that move to Utah are already familiar with the church when they move there. So these are states that are new receiving states, new destination states, and that are really struggling to develop the services to attract bilingual, bicultural professionals across all service settings: mental health, substance abuse, primary care, education, who can actually provide services to this growing community. So why do these stats matter? We've talked about education, we've talked about poverty, we've talked about the youthfulness, we've talked about their move into communities that are struggling really to incorporate this new wave of immigrants into their communities. Well, they matter because more than 60% of Latino youth live in low-income families, compared to 26% of non-Hispanic white children. And we know that low socioeconomic standing makes it hard for Latino children to receive the mental health care that they need, and other services as well. Hispanic children are the least likely of any minority demographic to receive mental health care services. Now, we know if the children, when we're as a society, we place our children above everything else. And when you look at these Hispanic communities, if the children are not receiving mental health services, we know that the parents are not receiving them either. So that's, it's an alarming fact. the need that may exist is not being met. So I'm going to pause here for a moment, and I'm just going to throw these 3 questions out. And as we shift over to this vignette on heterogeneity, I want you to keep these 3 questions in the back of your head, and hopefully you have something to write in front of you so you can make some notes for as we go through the vignette. So I want you to think about culture. You know, what cultures are represented in the vignette that we're going to look at, what languages are depicted, what faith, I was just talking about faith a moment ago, multi-generational issues, all issues that may be present in the vignette that may impact health and mental health and substance use issues. And that's the second question, what substance use and mental health issues are depicted. And finally, what strengths do you see that you can use in working with the family? We're highlighting, you know, some of the challenges with the Latino community, but there are many strengths to the community as well. And some of them are depicted in this vignette, and we'll talk about them towards the end of the presentation. So I'm going to switch my screen to the vignette. And it's a vignette called Latino Heterogeneity, and it's from a book by Asayas, Torres, and Kiriakakis called Culturally Competent Assessment of Latinos. That's the chapter, book chapter. The book title is Fermin and Nagy, Social Work Practice with Latinos, 2010. So I'll read through the vignette and then talk a little bit about it in the context of the questions that I put on the slide. Let me print one for me so when I switch over I can have it. So so the focus of the vignette is the identified patient, to use, you know, services lingo, treatment lingo, is Frida. Frida's an 8-year-old girl receiving services in a community mental health clinic to help her cope with her parents' recent divorce. Her parents came to the U.S. as young adults. Her father's from Ecuador and her mother's from Germany. Frida has 2 older maternal half-siblings, an 18-year-old brother and a 16-year-old sister. Both are half African American. The social worker initially met with Frida's mother, Gertrude, to get a family history, with particular emphasis on the various ethnic, racial, cultural influences that might be contributing to Frida's sense of identity. This was particularly important as it might color Frida's experience of her parents' divorce. Prior to the separation, Frida's father, Juan, was the primary caregiver while the mother worked. Juan's problems with alcohol were a contributing factor to the divorce. Although his drinking led to considerable marital conflicts, it didn't interfere with his caregiving toward Frida. In fact, Gertrude, Frida's mother, acknowledged that Juan was a warm, affectionate, and attentive father, and Frida had great affection for him. Although Frida did not experience any behavior problems or decline in her academic performance following the parent separation, at times she would appear sullen. Gertrude also noticed that Frida had not discussed her father at all following the separation. The social worker asked about Gertrude's family life prior to and following the divorce. Gertrude grew up in a home that was economically stable but very violent. Her father, who also drank heavily, was frequently physically abusive towards Gertrude, all 3 of her siblings, and her mother. Gertrude finished high school in Germany and left when she was 18 years old, primarily to get away from her family. She met her first husband several years after arriving in the U.S., and they had 2 children together. He passed away suddenly from a heart attack 7 years into their marriage. Gertrude reports that this was a very happy marriage, and her deceased husband remains the love of her life. She met Juan shortly after he arrived in the U.S. from Ecuador, which he left for economic reasons. Juan completed primary school in Ecuador, although Gertrude shared that he was very intelligent and was able to learn English very quickly. At the time they met, he drank, but not heavily. When they married, Juan was working in a service sector job, and Gertrude was employed as an entry-level office worker. She became pregnant with Frida shortly into their marriage. Juan lost his job when Frida was 2 years old, so he became her primary caregiver, and Gertrude became the sole household earner. At this time, Juan's drinking increased and became more problematic. Gertrude was laid off from her job shortly after her divorce and is currently receiving public assistance to support her family. She feels shame about the drop in her economic status and states that applying for public assistance was the most difficult thing she's had to do in her life. But she said she did it for the sake of her children. The social worker asked how everyone communicated in the household. Gertrude spoke to her husband and all 3 children in English. She stated that she does not speak German much because she really does not have anyone to speak it with. She did, however, say that the English she speaks with her children is sprinkled with German words. Juan speaks Spanish only to Frida, but she typically responds to him in English. Gertrude makes efforts to keep her children connected with their cultures because she feels it is important to their identity. She's still very close to the family of her first husband, who passed away 10 years ago, and makes sure that her 2 older children spend as much time as possible with their cousins, aunts, and uncles. They also continue to attend regularly a church she joined with her husband, a mostly immigrant Latino congregation from Central and South America. Gertrude proudly shared how the congregants speak to Frida in Spanish and how she responds politely in Spanish. So I'm going to go back to the slide. And so we talk about here, we look at culture. So you have a mom who's German. She's been in the United States for a while, so she's probably has some level of acculturation to the U.S. A father who's Hispanic from Ecuador, who again came to the U.S., learned English quickly, probably acculturated very quickly. And you have a family that's also mixed race. You have 2 older siblings from an earlier marriage to a man who was African American, so the children are a mixed race, and you have a mixed ethnicity child in Frida. You have multiple languages present. The mom speaks German, the children speak English. Spanish is also spoken in the home. Their faith community on the outside, they continue to attend the church that they attended with Frida's father, and it's mostly a Spanish-speaking congregation. So you have the 2 older siblings now exposed to Hispanic community and to Spanish. You have multi-generational issues here that the mother reports a multi-generational history of alcohol use, and then in her family of origin there's alcohol, and in her own family alcohol played an important role in the family separation. So these are all issues that are going to impact the presenting problems for the child who's the identified patient, but likely there are other issues at play here that we don't know. We're only scratching the surface. The mother may be struggling with some issues as well, and the 2 adolescents may be struggling with some issues as well. So you have substance use and mental health issues that are present. Typically, in a situation like that, it is the child who's first identified as having a problem, and then we begin to dig a little bit and we realize that there are other members of the family unit that are also struggling. But there are also tremendous strengths. Here you have a mother who's very, very, very proud, who displays an enormous amount of resilience in removing herself from an abusive family situation during her youth, moving to another country, establishing herself, making a life for herself, having a healthy and productive marriage that ended suddenly, and again she picks up herself and rebuilds her life. She cares deeply for her children to the point that she lost her job. She was able to put her pride aside and seek some help for her family financially. She's also taking steps to try to help her daughter succeed in school. A teacher has approached and said, well, there aren't really behavioral problems or academic decline, but something is different. And mom is being proactive in bringing the daughter to meet with a social worker. There are also support systems, this faith community that they belong to, and the family, the extended family of the father, the deceased father of the 2 older kids, are a source of support as well. So here's a mother who knows how to avail herself of the extended network, which is really important in Latino families. So these are all issues that we have to consider in assessing this family situation and putting together a treatment plan or a service plan for this family. And we don't really have time to go into it in more detail than that, but in the next couple of slides we'll summarize a few of these things. So why are these things important? Hispanics are disproportionately impacted by a variety of health disparities. And health disparities are defined as differences in incidence prevalence, mortality, or burden of disease, and other adverse health conditions that may exist among specific populations in the United States. And we say that a health disparity exists in a population if there is a significant disparity compared to the health status of the general population. So when you control for all other things like income, like education, etc., this disparity still exists. And Hispanics are impacted by a variety of them, particularly health and mental health disparities. Diabetes, for example, is of epidemic proportions in the United States, but it's very, very high as well in the Latino community. And hypertension. This metabolic syndrome, which is the combination of diabetes or insulin resistance, obesity, and high blood pressure, is epidemic in the Latino community. Hispanics are also disproportionately impacted by HIV. Substance abuse, depression, anxiety, and suicide, particularly in adolescent Latinas, is very, very big. And one of my colleagues, Dr. Luis Zayas at the University of Texas in Austin, studies suicide in adolescent Latinas. And also those of us that work clinically with populations have noticed that there's increasing rates of other types of conditions in the Latino community. Impulse control disorders, dysthymia, post-traumatic stress disorder, and eating disorders are on the increase. And interestingly enough, eating disorders are on the increase not just among Latinos in the United States, but in many countries in Latin America, eating disorders are increasing as well. Countries where eating disorders were unknown, non-existent 10, 15, 20 years ago. Many of these disparities are related to risk factors that are present in the Latino community, and some of these risk factors are in the last slide. There are cultural values that many Latino communities hold that have protective value to them, but that may also have risk factors to them. Family is one of them. You know, Latinos are very, very family-oriented. There's a cultural value known in the literature as familismo, the primacy of the Latino family, but sometimes that close family connection can move in the direction of enmeshment, for example, and in situations where substance abuse, for example, exists, the family-centeredness of the Latino community can be both a protector and a risk. Acculturation is a risk factor. You know, when we look at research data, as Latinos acculturate, as they embrace more of the mainstream way of thinking and the values and the practices and the behaviors, health indicators, health, mental health, and substance indicators, substance use indicators begin to increase, begin to worsen. As we saw, there's a lack of insurance coverage. Because of cultural and linguistic challenges, Hispanics are often misdiagnosed. Misdiagnosis leads to the wrong treatment. When you get the wrong treatment and things are not progressing, you're going to prematurely end treatment. So it starts a whole cycle that ends in the individual leaving treatment in the case when they come to treatment in the first place, which is rare to begin with. Poverty, as we saw, is a risk factor. Latinos experience stigma and discrimination. You know, in the last 5 or 10 years, the national discourse on immigration has been rabidly anti-immigrant and full of hatred and stigma and discrimination. That has changed somewhat since November. But, you know, the damage has been done. You know, historically, in all societies, when economies take a downturn, immigrant communities take the blame. And we have not been the exception. You know, Latinos have been getting a terrible rap in the media in the last decade until November, when they came out in force and supported the incumbent president. And all of a sudden, the discourse is changing. And of course, legal status. You know, as we know, we have an ongoing debate about illegal immigration, and there are about 11 or 12 million undocumented individuals in the United States, and an overwhelming majority of these are Hispanic because of the proximity to Mexico and to Central America. So these are risk factors that you need to take into consideration as well when you're working with the Latino community. And then lastly, this is my last slide, and then we'll open it up to questions. The strengths of the Latino population. You know, we're all in this webinar because we are service providers, and we want to know what are some of the challenges that this community experiences, but it's also important to recognize that the community has many strengths and that we can utilize these strengths as well when we are providing services for the community. Hispanics in general are individuals of deep religious faith and have a strong family orientation. They place high value on their children. Children are everything for Hispanic families, and Hispanics will move, you know, the earth and the sky in order to provide for their children. Hispanics have large, extended family networks. Many immigrant Hispanics, for example, continue to reside close to their families. You know, it's not uncommon to have all your relatives or most of your relatives living within a 2 or 3 mile radius. This begins to change as acculturation takes place, but in general, the extended family is present and close by. Hispanics have a high overall literacy rate. Even those that are not English proficiency are literate in Spanish, so there's high overall literacy rates. Incomes have improved. You know, Hispanics come to the U.S. to work and to better their lives. They're good at saving. They're good at being frugal. And over the years, their incomes have increased and continue to increase. And then lastly, it's important to recognize that many Hispanics, most Hispanic immigrants, actually I would say all Hispanic immigrants, come to the United States because they're highly motivated to work and to improve their lives. So they come to seek opportunity, and they make things happen. So I'm going to stop here, and I'm going to open it up to questions. And Cindy, I'm going to defer to you on how to handle the Q&A.
Hi, Dr. Torres. I have Doris and Jesus also on the line, and I think they're going to field the questions to you. There is one from someone. You guys have it?
Actually, we don't.
Oh, okay.
Yep.
Let me go ahead and ask the one that I see here now. Dr. Torres, how do we feel with the brief concept that when our people help someone else, it is in fact enabling the person, i.e. help your brother so he does not go to jail? And this is a Latino, Hispanic person that's asking the question, I assume.
Well, that's a very interesting question. You know, this whole notion of enabling as perhaps the ultimate expression of this family-centeredness. And you know, and you're right. You know, we can be supportive and embracing of our family members to the point where we are enabling their behavior. And your approach to that, I think, would depend on what setting you're working with the person in. And I'll give you a concrete example. In our in our study, one of the studies that we have here in the center is a study funded by NIDA, the National Institute on Drug Abuse, on the health consequences of long-term injection heroin use in aging Mexican American men. So we have a cohort of 227 men ages 45 to 80, and we did a lot of quantitative and qualitative data collection. But one of our field workers relates the story about, you know, being in a living room interviewing one of the participants in our study who was a current injection drug user, and the individual had actually used heroin prior to the interview, so he was nodding in and out of the interview. And the individual's mother walks in with a plate of empanadas and puts them on the table, you know, for the interviewer and for her son, puts them on the table, and in a very normal tone of voice, like nothing was going on, she says out loud, this son of mine, that he had left his paraphernalia out on the table because he had used shortly before the interviewer got there, and because he knew what we were there for, it wasn't a big issue. and the mom says, you know, this son of mine, you know, he leaves all his stuff around. One of these days, the police are gonna storm in and take us all to jail. And she puts, you know, the stuff away. She closes the box and she puts the stuff away. And the field worker, being a well-trained field worker, documented all of this. So I'm thinking we're debriefing the visit and talking about this, and I was wearing two different hats. And I'm thinking, you know, if I was a psychologist or a social worker or a substance abuse counselor working in a drug treatment program, and I was trying to help this individual stop using drugs and start on a journey of recovery, I would be pulling my hair out. I would be saying, this mother is enabling his use, this is terrible, how can we change this, etc. However, in that moment, I'm wearing the hat of a public health researcher, and I'm thinking, well, this mother knows what's going on, allows it to go on in the house, allows him to live there, feeds him. So this guy is not homeless. He's not living under a bridge. He's not, you know, injecting in a shooting gallery where he may be sharing needles with somebody else and increasing his risk of HIV, hepatitis C, other bloodborne disorders, or exposing himself to other types of conditions or diseases. So you have to, so one or the other, right? Now, it really isn't either or. I mean, it is possible to see this as something that, from a public health perspective, is preferable, and at the same time work with this family and work with this community to help them see that these cultural values of the importance of the family is really, really, really important, but that at some point a line must be drawn, and help them learn and use other types of skills to help get the son off of drugs. So it's not enough to just throw our arms in the air and say, oh, this is enabling behavior, I can't do anything about this. There are things that can be done about this. You know, there are clinical strategies, there's family treatment, there's psychoeducation to the community on both the protective factor and the risk factors associated with traditional Hispanic values. So what we can't do is judge, right? What we have to be careful about is, you know, judging the value, judging the belief, judging the behavior. We need to be creative and think, okay, how can I work with this community being respectful of this value and this belief? And respectful doesn't mean that I share it, being respectful of it, and perhaps engaging them in a dialogue about how to change some aspects of it. We don't want to throw out the baby with the bathwater. Right? A lot of times we go in, you know, guns blazing, and we talk about tough love, and it's a concept that may actually get the door thrown in our face. So we have to develop the relationship before we start to talking about, okay, this is problematic. How can we change it? I hope that addresses the question of the person who asked it.
Is there time for one more question, Cindy?
We have another question here.
Yeah, I think so. Dr. Torres is okay with that?
Oh, yeah. I'm fine. I blocked until 3:30.
All right. It says, I'm going to read it for you. It says, Dr. Torres, I have struggled with convincing parents that their adolescent may need to be evaluated for meds, for depression, in part because the parent heard from others that meds were addictive. Besides giving them education about meds, how do you get past the misinformation sometimes shared in the Latino community?
Well, you know, first of all, I want to say that's a phenomenal question, and I'm glad that the person has asked it. Second of all, I want to make the point that this is not a phenomena that is unique to Latino Hispanic communities. As we know, you know, in the last decade, there's been a lot of issues about vaccines and whether, you know, childhood vaccines cause autism or don't cause autism. And despite, you know, the scientific community coming out in strength and establishing that there is no causal link, and in fact, the original study that started this debate has been debunked, and all of that, you know, the dialogue continues, the miscommunication continues, the misbelief continues. Not just about autism. I think most parents, regardless of whether they're African American or Latino, Caucasians or Asians or from anywhere in the world, it's hard for a parent to hear, your child has a problem that needs medication. So that's, first we have to validate that that is a true concern. It's hard for a parent to hear that. Second, medications do have side effects. Even though not all medications are addictive, medications can solve some problems and create others. Now, all of that having said, it is true that many young people, many adolescents, have conditions that can be helped with medication. And one of the things that we can do to get parents to go along with at least assessments is empower them. A lot of times a parent that may have a lower level of education or less experience interfacing with the medical system may not understand that going to see a psychiatrist for a medication consult does not mean my kid is going to be on medication. At the end of the day, the parent has the last word. Right? So that's one piece of the puzzle, helping parents understand that just like when you go to a physician for a regular consult for anything else, the doctor can give you a prescription, but whether you're going to fill that prescription and take that medication is up to you. So parents have to be empowered. I think we also have to help connect them with other parents who have taken steps to provide medication for their children and who've had positive experiences with them. Our communities are very close. They're very tight. I was talking about the extended community a little bit ago, and what happens when you have a tight extended community is that miscommunication spreads like wildfire. You have one person who has a negative experience and the entire community knows about it in no time. So we have to find people who've had positive experiences getting their children's behavioral or psychiatric conditions under control with the right medication, and have those folks be the ones who provide the psychoeducation to the community. Parent is more likely to listen if he's hearing from another parent than if he's hearing just from a provider. And then the other thing is that we need providers that are bicultural and bilingual, who understand and respect the values and traditions and beliefs of the community, and that can find avenues to open a genuine dialogue between parents and the provider. I have worked with child psychiatrists who are phenomenal at doing this. I've worked with some that were not Hispanic or spoke Spanish, and they just had a way of engaging the family and helping the family understand what's in the best interest of the child and doing things on a trial basis. So these issues are real. They can be navigated, and they can be navigated successfully. But I want to repeat what I said in response to the previous comment. We got to get away from the automatic judgment. We jump to judge families. Oh, this mom doesn't want this. Look at how disturbed this kid is, and the mom doesn't want the kid on meds. She's a terrible mother. She doesn't care about about her child. And and I'm not saying that the person who's asking the question is saying that, but I have heard providers say that, and we need to get away from that. We need to get away from judging what we don't understand, and really make genuine efforts to understand our clients, to respect their values, and again, respecting doesn't mean sharing, and to try to work with them within the context of their cultural values and their beliefs.
Thank you, Dr. Torres. I have to say I really agree with you. The element of judgment sometimes does not allow us to see what's behind the symptoms that people bring to us. So I think that's an excellent point to bring up. We don't have any more questions right now. So I would like to take a moment to thank you again for all your help, and thank you for your presentation. We really appreciate your time. This has been a great presentation. I think everyone has learned a lot, and we hope maybe we can do something like this again.
Thank you, that is. And my email is there, so if anybody has any follow-up question or didn't get to, I know it was a lot of material to digest. I'm happy to respond back channel via email.
Thank you. Thank you for being available. Also, I would like to remind our attendees that an electronic copy of today's PowerPoint and audio will be available on the ATTC Network website at www.attcnetwork.org/itrainings. So if any of you wish to review that, you can probably get into the website and you'll find a copy of it. Also, your feedback is very important to us. So we conclude today's webinar, but I would like to invite you to join us also for our May's webinar, which will be on class standards. And it's going to be presented by our TA and training consultant, Mr. Victor Torres. As you leave today's webinar, you'll be directed to complete a really brief survey about your experience. Your feedback is very important to us, and we really appreciate you taking the time to tell us what you thought of today's webinar.